This People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and your brain.
CocoVia now comes in an even more concentrated formula with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels. The product undergoes rigorous testing at every stage to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
In honor of Brain Health Awareness Month, CocoVia is offering 30% off for all products on its website through Monday, June 8. That's cocovia.com, CocoVia.com. What do a rare condition called Castleman disease and COVID-19 have in common? Cytokine storm is a killer in both. This is the People's Pharmacy with Terry and Joe Graydon.
Dr. David Fajgenbaum has been battling Castleman disease since he was a medical student. He almost died 5 different times and did not respond to the usual treatment. He's had to chase his own cure.
What he learned about calming a cytokine storm might be invaluable for physicians trying to treat victims of the coronavirus pandemic.
Could insights from his rare disease help researchers repurpose old drugs against the coronavirus?
Coming up on the People's Pharmacy, chasing the cure for COVID-19.
In the People's Pharmacy Health Headlines, we've all been waiting for the results of a randomized controlled trial of hydroxychloroquine to treat COVID-19. The first of these has just been published, and the results are disappointing. The study, conducted in Minnesota and Canada, compared hydroxychloroquine with placebo to prevent infection in healthcare workers or family members exposed to people with the disease. More than 800 people participated in this research. They had had moderate or high-risk exposures and started taking the drug or placebo within 4 days of that event. Those taking hydroxychloroquine were not significantly less likely to become ill than those on placebo.
Public health officials continue to urge the use of face masks, physical distancing, and hand washing to reduce the spread of COVID-19. But many individuals seem unconvinced that such efforts are helpful. They point to a lack of scientific evidence. A new study published in BMJ Global Health suggests that such measures do indeed reduce the risk of spreading or catching the coronavirus. Researchers tracked 335 people in 124 families in which one person tested positive for SARS-CoV-2. The goal of the study was to determine how many people in the families caught the virus and if there were any strategies that worked to prevent secondary infection within 2 weeks of contact. Almost 1/4 of the family members became infected. The risk of transmitting the infection was highest before symptoms developed or early in the disease. However, when people in the family wore face masks, washed their hands, disinfected surfaces, and used good ventilation, transmission was reduced. When people were wearing face masks as a preventive measure before the first family member got ill, other family members were 79% less likely to catch the virus. If the initial patient had diarrhea, family members were 4 times more likely to get sick as well. However, disinfecting the bathroom and closing the toilet lid before flushing were helpful.
A meta-analysis of 172 studies confirms that wearing face masks and using eye protection, as well as maintaining physical distance, can reduce the risk of contracting COVID-19. Canadian investigators reviewed data collected from more than 25,000 volunteers in 16 countries. The researchers analyzed infection rates of coronaviruses, including SARS, MERS, and SARS-2. They found that maintaining at least 3 feet of distance was better than close contact. The farther away people were to each other, the lower the risk of viral transmission. The investigators state that face mask use could result in a large reduction in risk of infection, with stronger associations with N95 or similar respirators compared with disposable surgical masks. Eye protection was also associated with less infection.
Metformin is the most widely prescribed diabetes drug in the world. A few months ago, Singapore, Canada, and Switzerland recalled several metformin products from pharmacy shelves because regulators became aware of contamination with the probable carcinogen NDMA. Now, the FDA is notifying health professionals that metformin from 5 manufacturers may also be tainted. Those companies include Actavis, Amneal, Apotex, Lupin, and Marcans Pharma. The online pharmacy Valisure recently published a report suggesting that a number of other metformin formulations may also fail the FDA standards. Patients should not stop taking their metformin, but they may wish to request a replacement from their pharmacy if their pills are from one of the affected manufacturers.
Type 2 diabetes is among the most common chronic diseases in the United States. A new analysis of dietary data from American healthcare professionals suggests that certain dietary patterns are associated with lower risk. The data show that replacing fats and animal protein with high-quality carbs such as whole grains lowers the risk of type 2 diabetes. People who ordinarily consume refined grains can lower their risk by eating more saturated fat instead. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Some of the most frightening complications of COVID-19 can be attributed to cytokine storm, an overreaction of the immune system. One of our previous guests almost died 5 times because of a mysterious condition called Castleman disease, which also triggers cytokine storm.
To better understand this life-threatening reaction and how it might be treated, we turn to Dr. David Fajgenbaum. He's an assistant professor of medicine at the University of Pennsylvania. His book is Chasing My Cure, a doctor's race to turn hope into action.
Dr. David Fajgenbaum, welcome back to the People's Pharmacy.
Thanks so much for having me back.
Dr. Fajgenbaum, since we last spoke with you about your book, Chasing My Cure, COVID-19 has dominated the headlines. And one of the scariest complications of this infection arises when a patient suffers cytokine storm. Now, I'm suspecting until recently, most people have never heard of the term cytokine storm. And yet, this is something that you have experienced personally. Could you tell us your story, please?
Sure. So I went from being a healthy third-year medical student where I was training to become an oncologist in memory of my mom, who had passed away just a few years before from cancer, to having my last rites read to me because my organs were shutting down and I was hospitalized in the exact same ICU that I had previously been treating patients. I was experiencing, as you said, a cytokine storm, meaning that my immune system was hyperactivated and producing these inflammatory molecules that were causing my organs to shut down. And as I mentioned, I was so sick that I nearly died 11 weeks into it when I had my last rites read to me. And then unfortunately, I would go on to have multiple deadly relapses.
So what exactly is a cytokine storm?
A cytokine storm occurs when the immune system becomes hyperactivated and produces these inflammatory molecules called cytokines. Those cytokines help the different immune cells throughout your body to communicate with one another. It's a way for one immune cell in one part of your body to signal to another immune cell in a whole other part of the body that it's seen a certain type of infection. And there are different types of cytokines, and each cytokine has kind of a message that comes with it. And so when patients' immune system gets too hyperactivated, like it does in my case with my disease, idiopathic multicentric Castleman disease, or in patients with COVID-19, when the immune system gets too hyperactivated, it produces too many cytokines. And the problem is that when the cytokine levels get too high, it causes your organs to start to shut down. So your liver, your kidneys, your bone marrow, your heart, and your lungs begin to be dysfunctional. And that's exactly what happened to me. And I've now survived 5 of these cytokine storms in battling my disease, Castleman disease, with each one of them being very deadly. But thankfully, in my case, I received chemotherapy, which ended up saving my life by basically, we didn't know what cytokine to target or how to stop the immune system from being out of control. So we use chemotherapy to just kill the entire immune system. Of course, we don't do that in COVID-19. It hasn't been done as of yet because we're trying to figure out more nuanced ways to target and to basically diffuse the cytokine storm.
Your condition was very hard to diagnose. In the early going, your health professionals didn't really know what was happening. So, number one, can you tell us a little bit more about Castleman disease, like what it is, what experiences you had while you were undergoing these acute phases, and perhaps more importantly, what was it like to experience a cytokine storm? What did it feel like?
Sure. So Castleman disease is a rare immune system disorder. About 5,000 patients are diagnosed each year in the U.S. with Castleman disease. It basically sits at the intersection between cancer and autoimmunity. There are features of it that make it seem like a lymphoma and other aspects of it that make it seem more like an autoimmune condition. And the way that we get so acutely ill actually looks a lot like a viral infection. So it's a complicated disease that sits at the intersection of multiple other diseases. And as a result of how complicated and how little study had been done historically, it's been very difficult to treat. We don't know what causes it, and so that makes it really hard to control it. In my case, I mentioned I've received a lot of chemotherapy over the years. I eventually identified a drug because I mentioned I was diagnosed while I was in medical school, and I kept relapsing while I was in medical school. So I dedicated my life to trying to identify a treatment, and I did eventually identify a drug in the lab that I thought could save my life, and began testing it on myself. And thankfully, it's now been over 6 years that I've been in remission on this drug, and we're now applying this drug to other patients. And so I can tell you from kind of going through cytokine storms firsthand, there are a number of things that immediately come to mind when I think about each of my 5 cytokine storms. I think that probably the first thing is just the fear of going through this sort of an experience. Your organs are shutting down. Your immune system, which is supposed to be protecting you, it's supposed to be the good guy, basically turns into the bad guy and begins to attack your vital organs. And it's just frightening to feel basically everything shutting down simultaneously. In addition to the fear, there's also, for me and for others that go through these cytokine storms, this intense fatigue. When any of us get a cold or the flu, we feel really tired. And the reason we feel tired actually isn't the virus making us feel tired. It's actually the cytokines that are being produced to fight the virus that make us feel unwell and feel tired. So imagine if you had 100 or 1,000 times as many cytokines, you just feel incredibly fatigued. And then another feeling that is absolutely tied to a cytokine storm is pain. And the reason it's so painful is because when your liver and your kidneys shut down, you start to gain fluid everywhere. It's called edema, and you can get what are called effusions all throughout your body. And what's so painful about the effusions are that you basically, the sacs around each of your vital organs, your heart, your lungs, your kidneys, your liver, they begin to expand because of the fluid, and it causes really like knife-like pain, and it's really, really just unbearable pain. And so what I'm describing really is a really scary situation that creates fatigue you've never experienced before and pain like you've never experienced before. And the only way to kind of get all of these things back under control is to, in COVID's case, is to treat the virus and to control the cytokine storm. And in Castleman disease, it's to calm down this really intense immune hyperactivation.
What's going on in the brain? I'm kind of curious because we hear about people hallucinating, we hear about confusion, we hear about some of the brain toxicity that's associated with cytokine storm.
You're exactly right. All of the above. When I went through each of my 5 experiences where I spent weeks hospitalized with multi-organ failure from cytokine storms, I was incredibly confused because your liver and your kidneys both play really important roles in removing toxins from your blood and metabolizing toxins in your blood. And so they accumulate at such high levels that you become incredibly confused and you really don't know what's going on. And then there are absolute hallucinations that occur likely due to the high levels of toxins that are accumulating in the blood, but also likely related to many of the drugs that are being given to help to control the pain. Or if you're on a ventilator to actually try to limit your ability to move and try to pull the trach tube out. And so it's a scary situation. I mean, as I'm telling you all these feelings, I can imagine the listener, feeling some fear, and I think that I'm almost, feeling some of these memories coming back is making me or reminding me of just how difficult this situation is, and certainly making me think and send even more thoughts out for all of those people that are currently dealing with COVID-19.
Dr. Fajgenbaum, one of the conditions that we've recently seen with COVID-19 is a mysterious ailment in children in which they have multi-system inflammation. It's not just little kids either. It can affect young adults into their 20s. Can you tell us whether cytokine storm can inform our understanding of this complication?
Absolutely. So Kawasaki disease is a rare condition, but within the pediatric autoimmune disease field, it's actually one of the more common pediatric autoimmune conditions. And just as you mentioned, there has been a real spike in the number of Kawasaki cases all around the world, which are believed to be triggered by COVID-19. And so I think that what you're getting to is a really important aspect of this fight against COVID-19. And that's that when we think about fighting COVID-19, we cannot think about it in isolation. We cannot say, okay, we're starting from scratch at ground zero in our fight against COVID-19. What we really need to do is to look at all of these diseases that we've been studying for years, and that we have drugs that were developed for them, and that we have information, all these parallel syndromes, and to learn from them. So that way we are improving our fight against COVID-19. And similarly, that we can use what we learn in this fight against COVID-19 to take on these related diseases. I think that one major message and lesson that I learned from my fight and from nearly dying 5 times is this concept of needing to create silver linings. We're often encouraged during really tough times to look for silver linings. Something positive came from something really tough. But one thing that I learned from my mom, and that has certainly been true in my case, is that we need to look to create silver linings. And so in this case, creating a silver lining would be doing research to find the connections between Kawasaki and COVID-19, so that, to your point, we can start to improve care for patients who get Kawasaki syndrome. And I think that this is just one of hopefully many opportunities that we have to take what has just been such an awful pandemic and situation, and to hopefully try to find some positives from it where we can improve care for other conditions moving forward.
You're listening to Dr. David Fajgenbaum, Assistant Professor of Medicine in the Department of Translational Medicine and Human Genetics at the University of Pennsylvania. He's also Associate Director for Patient Impact of the Orphan Disease Center and author of Chasing My Cure.
After the break, we'll learn more about how we can treat cytokine storm.
Is it related to septic shock?
How can we identify existing drugs that might work for Castleman disease or even COVID-19?
Dr. Fajgenbaum will fill us in on his research on repurposing medications.
We'll find out why randomized controlled trials are so very important.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by ValiSure, the pharmacy that checks.
Approximately 80% of all drugs are produced in factories in China and India. ValiSure is the first and only online pharmacy that chemically analyzes every batch of every medication it sells at no additional cost to consumers. When you order online from ValiSure.com, you receive medicine that ValiSure has tested in their own analytical laboratory, shipped right to your door. And each medication or supplement from ValiSure arrives with its own certificate of analysis, so you'll know you're getting the medicine your doctor ordered.
Become a ValiSure customer and receive no charge shipping on your first order with the discount code PEOPLE. That's PEOPLE for no charge shipping. Remember to visit ValiSure.com. That's VALISURE, ValiSure, the company that checks.
This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's VERISANA.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
And by Cocovia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today, we're talking about how a rare disease might offer insights into treatment for COVID-19. Castleman disease and the coronavirus share a deadly complication caused by the immune system going into overdrive.
Our guest is Dr. David Fajgenbaum, Assistant Professor of Medicine in the Department of Translational Medicine and Human Genetics at the University of Pennsylvania. He's also Associate Director for Patient Impact of the Orphan Disease Center and author of Chasing My Cure, A Doctor's Race to Turn Hope into Action. It details his efforts to find an effective treatment for the rare condition that nearly killed him when he was a medical student and has come close several times since then. He's co-founder and executive director of the Castleman Disease Collaborative Network.
Dr. Fajgenbaum, we've been talking a bit about cytokine storm and how devastating it can be. You experienced it. It almost killed you 5 times because of Castleman disease. And now literally hundreds of thousands of people have died as a result of COVID-19 and possibly cytokine storm as the end result of that infection. Are there any other conditions? I'm thinking septic shock. I mean, this affects an awful lot of people around the world each year. Is cytokine storm relevant there as well?
That's correct. There are a number of ways that you can get to a cytokine storm. Basically, we use that term to describe this end product of immune hyperactivation. And you can get to having a cytokine storm from a viral infection like COVID-19. You can get there from a bacterial infection like you see in septic shock. You can actually also get there from having a malignancy. Malignancies can create and initiate these cytokine storms. And so there are a number of ways you can get there. And unfortunately, you have to treat each one of those cytokine storms a little bit differently. And in some cases, for example, in the Castleman disease cytokine storm, you may treat it with one drug, a drug like siltuximab or tocilizumab, and it may be really, really effective. Whereas you might get a cytokine storm from another cause, and those drugs may not be as effective.
Now, you've just mentioned some drugs. These drugs were not developed for Castleman disease. How do we find drugs that may already exist that could work in a situation such as Castleman disease or potentially COVID-19?
It's such an important question. When we spoke last, we spoke a lot about drug repurposing and the potential for taking drugs approved for one condition and trying them for another condition. The drug that I'm on right now, I'm literally alive and talking to you guys today because of a drug, sirolimus, that had never been used before for my condition and was developed 30 years ago for kidney transplantation. And this sort of concept of drug repurposing, I just feel so thankful to be alive, and I want to share this approach with other patients with other diseases, because how many, I ask the question all the time, how many diseases are there out there where there's a drug that already exists, we just don't know about it? And so drugs like siltuximab and tocilizumab actually were initially developed for Castleman disease, and now they're being used in a number of other conditions, including they're two of the most high potential candidates for COVID-19. And this is a concept, drug repurposing, that many of us have been very optimistic about for a long time, myself, because I'm alive because of one of these drugs. But I think that COVID-19 has brought to light the importance of being able to move quickly towards hopefully identifying a drug that could be repurposed right away.
Well, some of your research is involved, in fact, in trying to find medications that are out there that could be repurposed for COVID-19. In fact, remdesivir, which was sort of sitting on the shelf at Gilead, a drug company that has been involved in antiviral research for a very long time, was in part developed for other kinds of viral infections and didn't work very well. So can you tell us a little bit more about repurposing drugs and what your lab and what you're personally doing to try and find medications that might work against the cytokine storm of COVID-19?
Sure. The approach that we take in looking for drugs that can be repurposed, we start out by doing unbiased discovery level studies. So things like genomics and serum proteomics, where we look at things from a really unbiased lens, and then we analyze the data to look for any sort of really strong signals that could suggest that one particular communication line or cell type might be important. And then once we get that signal, then we start to dive really, really deeply with further experimentation. And then we look for all the drugs that are already FDA approved, and we ask, can any of these existing drugs turn on or turn off the thing that we found to be really high or really low abnormally in our samples? Then we start testing those drugs in the test tube. We do in vitro experiments to prove our hypothesis or disprove our hypothesis. And then as soon as we get a signal that some drugs may be effective, we communicate that out to the medical community. And oftentimes those drugs are then used what's called off-label, meaning that they were already approved for one thing and now you're trying them in a new way. And when that does happen, we systematically track how well did that drug work versus how well maybe it did not work. And drugs that are very promising, we move forward to clinical trials. So this process of kind of moving from totally unbiased towards a large-scale clinical trial to test out a drug is a process that we've been doing in our fight against Castleman disease and have been very successful. It's particularly important for diseases like Castleman's and like COVID-19, where they're very deadly and where we need solutions now. And so we've been taking this approach for many years. And I found myself in early March hoping and praying that some research group out there would follow our blueprint. As we mentioned earlier, I wrote a book called Chasing My Cure, all about this process of going from no treatments to treatments, literally chasing after cures. And I was hoping that maybe some researcher out there would read the book, maybe they would follow this blueprint, maybe they could learn from our experience. And about 30 seconds into that thought process, I said, well, wait a minute. If I'm going to hope that some researcher somewhere does this, I run a lab that's focused on cytokine storms. We've been able to identify drugs for repurposing, and I'm alive today because of it. Maybe I should stop hoping, or even better, maybe I should turn my hope into action, and I should get going on this fight against COVID-19. So it was March 13th, that Friday, and that next Monday, I was able to turn to my team members, and they all agreed that we should refocus a large portion of our effort towards COVID-19. And so we are now basically going through the same playbook we went before in Chasing My Cure, now to Chasing COVID's Cure. And one of the first things we did is, thankfully, we were really pleased to see that there were already a number of drugs that were already being tried. And I say thankfully because when you have a disease like this, you don't really have time to wait months or years before you test a drug out in humans. Thankfully, people were testing these drugs, but unfortunately, there was no database or registry to track all the drugs being tried. And so one drug would be given and it would work, another drug would be given and it wouldn't work, but none of this data was being collected in a central place. So we started what's called the Corona Project, where we assembled a team of now over 40 volunteers that have been reading through every single published paper on COVID-19. We're now up to over 7,000 papers that have been reviewed, and we've extracted data on over 13,000, or no, I think we're now up to over 18,000 patients. That's just in the last few weeks. Where we've been able to identify over 150 different drugs have already been tried in this first 18,000 plus patients. So drugs are being tried off label. Importantly, we're now tracking how well they're actually performing and how frequently they're being given. And then we use those data to then determine what drugs should move forward to a formal clinical trial versus what drugs maybe seem to be less interesting. And actually, the first paper based on this research was just published today.
Wow, that's very exciting, but it's also very controversial. And I say controversial because two of the drugs that got the most attention right out of the starting gate were hydroxychloroquine and azithromycin, in large measure because of a French researcher in Marseille who was recognized as one of the world's foremost authorities on viral infections. He had a great reputation, and he was pretty much all in when it came to the old malaria drug, hydroxychloroquine, as well as its predecessor, chloroquine. And, people really have become very polarized. I mean, to this day, there are a lot of people who say this is the most appropriate treatment, and it's great, and it's a cure, and it'll prevent the disease. And then there are other people who have written in New England Journal of Medicine, JAMA, and most recently in Lancet, suggesting that, maybe it's not the cure we were hoping for, and there are some downsides with cardiac arrhythmias. So I wonder if you can, just share briefly what your thoughts are on hydroxychloroquine, azithromycin, and the possibility that sometimes what looks hopeful initially may not turn out to be as effective as we would have hoped.
Sure. I remember when that first study came out of just 20 patients, I remember being so excited, just like I feel like the whole world, I think, jumped up and down at the idea that this drug or this combination of drugs could really make a difference against COVID-19. As excited as I was early on, I think I was equally disappointed with each of the more recent studies that have come out. Just as you said, I think, unfortunately, this has become quite polarized. And so some people, no matter what the data shows, will say it works. And some people, no matter what the data shows, will say it doesn't work. I think that the majority of us, I hope, really do want to follow the data and recognize that COVID-19 presents some real limitations when it comes to clinical research. So in a disease like Castleman disease, or let's say pancreatic cancer, where no one gets better without therapy, everyone uniformly dies if you don't treat them. In those sort of situations, if you give people drugs and they get better, then you have a pretty good sense that this drug probably worked, because basically everyone dies without treatment. But in COVID-19, as you know, nearly everyone actually survives COVID-19. And so if you give a treatment to a group of people and they survive, you don't know if they survived because they would have survived anyway, or if they survived because of the drug. And so that's why it's so important to do these randomized controlled trials where you randomly put one person in this on drug and one person not on drug. And then you randomize over a large number, and you can say, okay, people who got this drug at random, they had a higher likelihood of improving versus patients who didn't. And as these studies have moved forward from just 20 patients, as you mentioned, in France, to now hundreds of patients in large trials, the data are not nearly as compelling as we move into having control groups. And that's unfortunate, because I think all of us want these drugs to work. But more recently, I'm certainly much less enthusiastic than I was early on.
The importance of randomized controlled trials is clear, perhaps, to researchers. It's a little less clear, perhaps, to some of our listeners. Could you just review that one more time?
Sure. So in a disease, as I mentioned earlier, like Castleman's or pancreatic cancer, if everyone uniformly will die without treatment, then you can do a small study where you give a drug, and if people get better, you can get a sense that, okay, the drug likely helped to keep them alive. It's probably the drug. But when you have a disease where nearly everyone with COVID-19 will survive COVID-19, unfortunately, there is a significant and important and should not be forgotten portion of people who will not survive from COVID-19 if they're not given treatment. But it's a small percentage, which means that because it's such a small percentage, the majority of people that get COVID, if you just randomly give a drug to a large number of people, most of those people would have gotten better anyway. And so what you really need to do is you need to focus your trials just on people who unfortunately would not have gotten better without treatment, the people who would have to go on a ventilator, or who would unfortunately pass away if they're not treated. That's the group you need to focus in on for these trials. And when you do the trials, you need to make sure you have a group who doesn't get the drug and a group who does get the drug. And then you know that if people get better when they got the drug, that it's a drug that got them better, and it's not just the fact that they would have gotten better anyway.
Dr. Fajgenbaum, one of the what we'll call arguments for hydroxychloroquine and azithromycin that we've heard from literally dozens, if not hundreds of visitors to our website, is that you have to treat early. You can't wait till people are almost on a ventilator. You actually have to give the medication almost before they have symptoms, which seems like a real challenge if you're trying to develop a clinical trial.
You're absolutely right. The good news is there are actually a number of really well-designed clinical trials that do get to this important question, because I agree it's also about timing. It's not just about what, but it's also when. And thankfully, there are at least a few that I can think of, large trials of healthcare professionals. So people that you know are at high risk of developing COVID-19 because they're interacting with patients every day. And it's one group of people of this large healthcare organization will get those drugs, and then one group will not get hydroxychloroquine or azithromycin. And so this is a great way to test, exactly as you said, people who can get the drug early, maybe even before they even encounter the virus, and see if people who get the drug early, if they end up having better outcomes than people who don't. And in this case, you're not going to use survival as the outcome, because most of these people probably would survive, but you can use the time to improvement of symptoms, or you can use the time to discharge from the hospital if they do end up being hospitalized. So you're right. It shouldn't just be the sickest patients, but the key isn't so much about intensity of the disease. The key is about making sure that you can have a group of people who are at a similar stage who don't get the drug, so you can prove that it works. And I think that hydroxychloroquine plus azithromycin, due to the recent concerns with cardiac abnormalities, I think there's a very strong case that could be made that it's possible that taking a placebo could potentially be better than taking hydroxychloroquine and azithromycin as far as your risk of death. And so I think these controlled trials are really important to do. And I think all of us really hope that azithromycin plus hydroxychloroquine result in improvement. I think every one of us does. I hope everyone does. But we have to do the trial to prove it. And the good news is that I think there are a number that are set up to answer this exact question.
You're listening to Dr. David Fajgenbaum. He's an assistant professor of medicine at the University of Pennsylvania. His book is Chasing My Cure, A Doctor's Race to Turn Hope into Action. He's Associate Director for Patient Impact of the Orphan Disease Center at the University of Pennsylvania. Dr. Fajgenbaum is also co-founder and Executive Director of the Castleman Disease Collaborative Network.
After the break, we'll find out more about his work with the FDA, developing off-label guidance for drugs that can be repurposed to treat COVID-19.
What do we mean by off-label drug use?
How is the Castleman Disease Collaborative Network involved in this research?
We'll also find out which medications Dr. Fajgenbaum is most excited about for the potential for treating COVID-19.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Today our topic is cytokine storm. That's the medical term for an immune system in overdrive. It's responsible for many of the most devastating complications of COVID-19, and it's an important and often deadly feature of the rare condition called Castleman disease. Our guest is using his experience with Castleman disease to help patients with COVID-19.
We're talking with Dr. David Fajgenbaum, Assistant Professor of Medicine in the Department of Translational Medicine and Genetics at the University of Pennsylvania. He's also Associate Director for Patient Impact of the Orphan Disease Center and author of Chasing My Cure, A Doctor's Race to Turn Hope into Action.
Dr. Fajgenbaum, I wonder if you'd tell us about your work with the FDA in developing some of these off-label repurposed drugs for COVID-19.
The FDA has been really, really great to work with, both before COVID-19 and more recently on this concept of drug repurposing. Historically, the FDA had been pretty negative around the concept of drug repurposing, and certainly around any sort of advertising that a drug that's approved for one condition should be used for another. And the FDA is still firmly against that, as it should be. If the drug has not been tested for a new condition, it shouldn't be advertised as a drug for that new condition. But more recently, I've noticed a trend within the agency towards recognition that there is a lot of off-label drug use that occurs. In fact, the numbers are not perfect, but the guesstimate is that somewhere around 1/4 to 1/3 of all prescriptions are actually off-label prescriptions, meaning that they're being written for a condition that the drug is not actually approved for. So there's a lot of off-label drug use that is already happening. And I think COVID-19, but also many rare diseases have brought to light the urgency of looking at existing drugs, and especially when these are drugs that are safe and that can be effective for at least one condition. So the FDA more recently has been very interested in ways to capture data around off-label drug use and ways to think about how those data could actually be used for them to consider expanding a label. So making a drug that's approved for one condition, expanding it to have another disease that it's approved for. I've been really impressed with the agency's interest. Recently, there was an app that was developed called Cure ID, and that app was specifically developed by the FDA to capture off-label drug use in infectious diseases. It's for thinking about bacteria that might be susceptible to certain antibiotics versus others. But of course, it's now being used for COVID-19. When the FDA developed the app, of course, I didn't know that this was around the corner, but it's being able to be used as a way to track off-label drug use in COVID-19. So I think the good news is that there's a real appetite within the agency to capture this data and to see, what can they do to help the public's health by helping to uncover drugs that could be repurposed.
There's a lot of confusion about off-label drug use. Perhaps you could explain that any physician can prescribe any medication for any purpose as long as he or she believes that it would be beneficial to his or her patients. So you don't actually have to have FDA approval, for example, to prescribe sirolimus for Castleman disease, even though it was initially approved for kidney transplant patients. But there are literally dozens, if not hundreds, if not thousands of situations where doctors can prescribe, for example, hydroxychloroquine if they believe it's going to be helpful. They don't need the FDA's approval.
That's right. All you need is one approval. Once a compound gets an approval for one condition, as you said, it can then be prescribed for any condition under the sun. There are two questions that have to be answered when someone does off-label drug use. The first is it likely that this drug is going to work for this patient? And that is a conversation that the patient and the doctor need to have about why the doctor or the patient thinks that a drug that is not approved for this condition might actually work. And if the doctor and patient think that it's likely that this drug could actually work and will do more good than harm, then the next question is will the payer pay for it? So will the insurance company or the federal government, if they're covered by the federal government, will they actually pay for it? And this is where it really comes down to dollars and cents, because if it's a very, very expensive drug and it's not approved for this condition and it's never been used even once for this condition, then I can almost guarantee you that it's probably not going to get paid for by any payer. But if it is a cheap drug and it's a condition where there are no other options and the patient will die, then that's where the insurance company will oftentimes grant access to the drug, and they'll actually pay for the drug. And again, I shouldn't say grant access, because they're not deciding whether it can be accessed per se. They're just deciding whether they're going to pay for it. And it's very gray whether insurance companies will actually pay for these new uses. Typically, they'll pay for new uses, or they'll pay for off-label drug use when there's at least some data out there to say that it's likely to work. In my case, I was the first patient to ever receive sirolimus with my disease. And amazingly, my insurance company didn't ask any questions. And I think the reason is that I had spent literally months in the ICU. I don't know how much I cost my insurance company, and how, months of such expensive care, so many chemotherapies. I nearly died 5 times, and medical technology and drugs kept me alive. And so I think that when this cheap generic drug was presented as an option, I think that they said, sure, if there's a chance I could help. But the calculus is going to be different for every disease.
Dr. Fajgenbaum, you are the founder and executive director of the Castleman Disease Collaborative Network. Can you tell us about it, and tell us too, why is collaboration important in general and specifically with regard to COVID-19?
A couple years after I was diagnosed with Castleman disease, I nearly died for the fourth time, this time while I was on the only drug to ever undergo a randomized controlled trial for my disease. And my doctor explained to me that there were no more drugs in development and that there were no more promising leads. And at that moment, I promised my family, my dad, my sisters, and my girlfriend, that I would dedicate the rest of my life, however long that may be, to trying to identify a treatment and maybe even a cure for Castleman disease. I started out by first conducting laboratory research, hoping that I could identify a drug that could be repurposed that already existed, but I recognized that it was unlikely that I could make enough progress on my own. So I launched the Castleman Disease Collaborative Network initially to follow a similar sort of approach that other rare diseases had taken, but I quickly realized that we could no longer follow the traditional approach, and that's to raise money and then hope the right researcher applies for the right project at the right time. So we created an international network of physicians, researchers, and patients, and then we actually crowdsourced from the entire community to get perspectives from all of these stakeholders, and then we prioritized the most important research questions and ideas from this entire community and went out and recruited the right researchers to perform the studies. This is a very different approach to research. It's one that really relies on collaboration and a strategy and a plan, as opposed to the more typical approach of kind of waiting and hoping. And we're now trying to replicate that against COVID. And we're trying to facilitate a similar sort of environment. The Corona project I mentioned earlier is freely and openly available to anyone who wants to go to the website, cdcn.org/corona. And so this sort of data sharing that's open and collaboration, I think, is absolutely critical to both how we think about research in general, but also to COVID-19.
Dr. Fajgenbaum, I love your motto, turning hope into action. Where do you see this research leading?
I see the research that we've done thus far helping to make sure that right now there are a few drugs that have a lot of people's attention in the fight against COVID-19, but we've shown that there are actually over 150 other drugs that have been tried, some of which look really promising. So I see our approach of turning our hope for a treatment and a cure into action and helping to identify drugs that likely would have fallen off the radar, that maybe like sirolimus, you wouldn't think would work. But because we've tracked them and because we are looking for trends, that we're able to move those drugs towards clinical trials that can show benefit and hopefully be able to help more and more patients with COVID-19.
And in the minute or two that we have left, Dr. Fajgenbaum, which drugs are you most excited about right now? What do you think holds the most promise over the next couple of months and year?
I think our research has shown us that COVID-19 is very heterogeneous, and as such, we expect that different drugs are likely going to be needed for different kinds of patients. With that in mind, the most severe cases tend to have the cytokine storm, like we spoke about at the beginning of the show, and there are actually a number of Castleman disease drugs that were developed for Castleman's that are very good at stopping the Castleman cytokine storm, like tocilizumab and siltuximab. Those are right up at the top of my list for drugs that I'm most optimistic about. And thankfully, there are a number of trials that are currently open that will really be able to definitively answer that question.
Dr. Fajgenbaum, we've heard an awful lot in the last few months about patients in the ICU and the incredible anxiety that has created for them and their families, what it's like for the healthcare professionals who staff the ICUs, for people to be put on a ventilator, and how unbelievably scary that process is. You're a person who has spent time in the intensive care unit. Mm-hmm. Can you tell us a little bit about what that was like for you and your family?
I can say that for me, I can't even imagine what it would have been like to spend those months in the ICU without my family next to me. And I think that that's one of the things that breaks my heart the most with what we're facing with COVID-19, because oftentimes family members are not allowed in the ICU with their family. And having my dad and my sisters and my then girlfriend, now wife, by my side encouraging me to breathe when it was so painful to breathe that all I wanted to do was give up, and that I didn't have the strength myself. I didn't have enough strength to fight, but because I had my family with me, they gave me the strength that I needed. And to think about going through the same sort of thing without that is so scary. And it reminds me actually of when I was finally being discharged from the hospital after spending about 6 months hospitalized at that stage. And one of the nurses asked me, "David, are you excited to get out of the hospital?" And I said, "Yes, I've been in the hospital for the last 6 months. I cannot wait to be discharged." And my dad said, "What is this? I've been in the hospital. We've been in the hospital." And he was absolutely right. He had been by my side supporting me, and that helped me to get through it. And so I think it breaks my heart to think about all the patients right now that don't have that support. But I have been so thankful to hear stories of ways that nurses and doctors have been able to maybe provide support in ways that maybe they wouldn't typically, because they know that that these patients don't have their families. And it's been really heartwarming to hear about the extra support that they're providing, and about making sure that cameras and Zoom videos can occur whenever possible, because boy, do we need one another during really tough times.
Dr. Fajgenbaum, I wonder if you'd share with us the lessons that you may have learned from surviving those 5 terrifying near-death experiences.
I learned so much about life and hope and resilience from each one of those near-death experiences. The first lesson that comes to mind is this concept of overtime. We know overtime from sports events where it's extra time you didn't think you'd have, but in overtime, every second counts. You can make a mistake in the first quarter and you can make up for it, but you can't make a mistake in overtime. And I've really felt like I've been in overtime ever since I had my last rites read to me, and I nearly died the first time. And overtime can seem scary and limited time, and it is. But overtime can also create clarity. And I think that all of us, as we think about COVID-19, are all feeling a bit of a sense of overtime, that we could get sick at any moment, or someone we love could get sick at any moment. But I hope that we can use this sense of overtime to really find clarity in our lives around what's most important and maybe what's not as important. Another lesson is something I also learned from my deathbed, and that was that I didn't regret anything that I had done in my life. I regretted only the things that I had not done or I had not said. And so I created a motto that I still think about daily, and that's think it, do it. If you think of doing something and it's the right thing to do, you should do it. And you shouldn't live with regrets is certainly a cliche, but I think it's a cliche for a reason. And that if I think about doing something, I do whatever I can to do that thing. Another is the power of humor and laughter. I think that when you hear someone's in the ICU, you may think that laughing and humor is the last thing that someone would need in that situation, but actually laughing with the people that I love, my family and now my wife, during really tough times, that helped me to make it through some of the times that I honestly didn't think I would survive. And I talked earlier about the concept of turning hope into action. I had hoped for years that some researcher somewhere would find a treatment or a cure for me. And then eventually I turned my hope into action, and I got to work for Castleman disease. And thankfully, when it comes to COVID, I was faster to move from hoping to action. And I'm hopeful that we can make an important step forward in the fight against COVID-19. And maybe the last thing that I would share is the importance of working together. A lot of times you hear people say it takes a village. I like to say it takes an army, and that there's really no way that any one of us could have done this in our fight against Castleman's on our own. And there is no way that any one of us can do this in our fight against COVID-19. So it really, in my opinion, is going to take all of us working together, fighting together, sharing lessons from this fight, but also sharing lessons about life, because these things I learned on my deathbed, these lessons, I wish I didn't have to go through them to learn them, but I want to share them with the world, which is one of the reasons why I wrote Chasing My Cure. One of the reasons why I wanted to share these lessons with you guys today is that I don't want you to have to go through all this to learn these lessons that have been so important to me.
Dr. David Fajgenbaum, thank you so much for talking with us on the People's Pharmacy today.
Thanks so much for having me.
You've been listening to Dr. David Fajgenbaum. He's an assistant professor of medicine at the University of Pennsylvania. His book is Chasing My Cure, A Doctor's Race to Turn Hope into Action. He's Associate Director for Patient Impact of the Orphan Disease Center at the University of Pennsylvania. Dr. Fajgenbaum is also co-founder and Executive Director of the Castleman Disease Collaborative Network. To find the information online, visit peoplespharmacy.com.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC. This week, the show was recorded from our home studio.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by CocoVia, offering plant-based nutrients in the form of cocoflavanols for brain and heart health. Online at cocovia.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1215. The number again, 800-732-2334, online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. You could also subscribe to the podcast.
When you visit the website, you can also sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.